Hi, Hussein. How are you? Can you hear me okay? We are waiting for our guest speaker to arrive. We will start in around 10 minutes. Sure, thanks for coming. Hi, Katie. Hi, Gary. Hi, Vivi. Hi, Brett. We'll start in around 10 minutes. Thank you for coming. Hi, Sylvia. How are you? We are starting in around 8 minutes. So, thank you for coming. Your unmute button, if you want to say something, is on the bottom right corner. There's little microphone symbol. Thank you.
Hi, Katarina. Yeah, I was just, yeah, I don't have a lot of experience with
Oh,
with this app, but I was just actually I was just listening to a pre-recorded one, and our chat is scheduled for July 27th, right?
yes. Exactly.
Okay, great, which is tomorrow.
Yeah. Do you want to have
Okay.
like a meeting after this? If you want, we can have a meeting to go over, or do you just want to see how things work right now, and then that's enough?
Yeah, so so sorry. I think I'm
Oh, yeah, yeah.
misusing the app. No, it's going to be, it's fine. It's fine. Sorry.
Oh, no, don't worry. So you see here on the top right there, I shared the PDF. So if you want to use slides tomorrow,
Uh-huh.
we can do the same thing. So Odile, she sent it to me, and then I uploaded it to our Science Society Google Drive and made it shareable, like for everyone to view.
Uh-huh.
So
Yeah, sure.
and then hi Frank, how are you? And then how so everyone has to scroll through the slides themselves. So it's really helpful if you have slide numbers, and when you switch to next slide, just say now I'm switching to slide number 9 and so on. So it's not the screen share, so that's a little bit different from probably Zoom and so on that you probably usually use.
Great.
But thank you for coming, for taking the time and being here. That's nice.
Yeah, no, thank you for inviting me to this event. I just wanted to to check how it worked. Thanks so much. So you will put we will put the link to the paper. So I will just talk
Okay.
about
Yeah.
the number of pages. Okay?
Exactly. Yeah. Okay. Perfect.
Great. Thank you very much.
Thank you,
I will
Sylvia.
connect tomorrow, like 10 minutes before,
Yeah.
perhaps.
Yeah, I'm always around
Okay.
5 minutes before here. So, yeah, perfect.
Okay, great. Thank you very much. Thank you.
Sure. Thank you. Hi, Frank. How are you today?
Yeah, hi there. I'm just getting in.
Sure. We'll start in around 5 minutes. So, thank you everyone for coming. This will be a really interesting talk from our guest speaker. She's at the university in Brussels, and yeah, I think it's a very important new technology she developed in her team for children with epilepsy. So yeah, stay tuned. We'll start soon. Oh, thank you, Red, for the comments. Yeah, I appreciate it. Thank you. Hi, Odile. How are you?
Hello. Can you hear me?
Yes. We have like some maybe interference noise. Are you using headphones? Maybe.
Yes, I'm using headphones.
Well, now it's actually fine.
Okay.
The interference that was kind of clicking on the volume, I guess.
Yes, I was switching the volume.
How are you today? How was your day so far?
I'm fine. And you?
We are very happy that you're here. So thank you. For us, it's a good day already.
I hope you will be the same way after the presentation.
Oh, much happier because I learned from you. Of course. Yeah. Yeah, we'll start in around 2 minutes. So thank you for doing this and for making the account and everything. So we really appreciate it. Thank you. Okay, I think we can slowly start. Welcome everyone to Science Society, and a special welcome and thanks to Odile Face. And before we start, let me introduce you to the audience. Um, Odile Face, she graduated as a medical doctor from the Université Catholique de Louvain. I hope I'm saying it right.
Yes,
I
it's
don't
good.
know French. I'm really, I'm from Europe, but I just know German, Portuguese, and Spanish.
No,
No
it
French.
was
I'm
perfect.
sorry.
It was
uh,
perfect.
and she's currently a resident in neurology at the Erasmus Hospital, also in Belgium. And she's also a PhD student in the Laboratory of Translational Neuroanatomy and Neuroimaging from the Université Libre de Bruxelles in Belgium. And in her PhD project, she wants to develop new methods for enhancing the elimination of the epileptogenic zone. And I would say you're being very successful with it. And congratulations for your paper.
Thank you.
And yeah. And before we start, we usually start with like a couple of interview questions. And our first question is, how did you become interested in doing science? Was there an amazing teacher in your life, or was that always something you wanted to do? I think this question is really interesting for people that are maybe not in science. Thank you.
I was looking for a good answer to this question, and I didn't find the starting of my interest in science. And I guess it maybe because my mother is a teacher of chemistry and physics, and so we were doing some experiments in the afternoon after school in the kitchen about such chemistry, physics, I don't know. To test a lot of things really various in the life in the daily life, and that's, I guess there is no starting of my interest. It's maybe because since I was young, I was doing some little experiments, scientific experiments in the kitchen. So
That's so interesting. My father, he's also a chemistry and physics teacher, and same thing with me. He always tried first the experiments with me, and if it would work, then he would do them.
exactly the same. I
And he would
tested
bring
all the
home.
experiments of my
Yeah,
mother.
yeah, exactly. That's so funny. That's so interesting. That's amazing. So it was always part of your life, which is wonderful. And how did you start working in the field you're in right now, and how did this project come about? Is there maybe? Yeah, thank you.
So I was studying medicine to become neurologist because I already thought it was highly interesting to better know the brain, etc. And I'm particularly interested in epilepsy for a long time, and so I was looking for a PhD project around the management of refractory epilepsy, which was my particular interest is in management of refractory epilepsy. So, and this project is, in the field, fit perfectly with the field.
Great. So everything worked out wonderfully, and congratulations to the paper you're presenting today and the work you're presenting today. So, yeah, the stage is yours. We'll keep the questions for after the presentation for the end. And thank you, everyone. And yeah, the stage is yours, Odile. Thank you.
Thank you. So my presentation is about on-scalp magnetoencephalography as a new diagnostic tool for the evaluation of epilepsy in children. And I switch to the second slide. To introduce you the topic, you need to know some specific word in the field of epilepsy because I will use it again and again in the presentation. So you need to know some specific word as seizure, which is a transient occurrence of signs or symptoms due to abnormal, excessive, or synchronous neural activity in the brain. And when I use the term ictal, ictal discharge, for example, it means during the seizure, and when I use the term interictal, it means between seizures. And then epilepsy is a disease of the brain defined by any of the following conditions: at least 2 unprovoked seizures occurring more than 24 hours apart, 1 unprovoked seizure and a probability of further seizures of at least 60% over the next 10 years, or diagnosis of an epilepsy syndrome. So the first line treatment in epilepsy, it consists of anti-epileptic drugs, and the main outcome is to reach seizure freedom. Nevertheless, despite the correct intake of at least 2 correctly chosen and well-tolerated anti-epileptic drugs, some patient does not reach seizure freedom. They suffer from refractory epilepsy, and in patients suffering from refractory focal epilepsy, there could be around 50% of these patients could be candidates for epilepsy surgery, which aims also to reach seizure freedom. Despite this surgery, around 40% of patients does not reach this outcome. And the current gold standard of epilepsy surgery consists of surgical resection of the area where seizures are starting. This area is called epileptogenic zone. And you can think if patient has a brain lesion, it is okay to remove the lesion, and it's not the case in most of anatomopathological lesion type. As you can see on the slide 4, you can see in red the lesion, and in most type of epilepsy, the epileptogenic zone will be larger than the lesion. Thus, we need to define the epileptogenic and delimitate it correctly before to remove it. Then on the slide 5, you can see that we need some tools to help us to define this epileptogenic zone, and there is a first step in these tools, which includes clinical evaluation, MRI, neuropsychological assessment, and video EEG, video electroencephalography, including ictal recording and interictal recording. It's not on the slide, nevertheless, in our center, and I guess in most of European center at least, PET is also in this first part, and it is an isotopic imaging. After this first part, if all of these results of this clinical assessment are concordant, we can decide if patient can benefit from surgery or not. In some cases, results are discordant, and there is a second sample of tools which help epileptologists and clinicians to decide if patient can benefit from epilepsy surgery or not, and to better define the epileptogenic zone. And MEG, or magnetoencephalography, is a part of this second sample. And I'll talk you about the magnetoencephalography, which is the topic today. And how does it work? Magnetoencephalography will record the magnetic field produced by brain. There is 2 types of sensors to record this magnetic field. I forgot to say, I'm on slide 6. These 2 types of sensors are magnetometers and gradiometers, and magnetometers record magnetic field around them, and gradiometer will record magnetic field just below and perpendicular to them. All the sensors are located around the scalp, and there is around 100 locations to record the most of the magnetic field produced by the brain. Each location, as you can see on the right on slide 6, are including 1 magnetometer and 2 gradiometers perpendicular between each other. The brain magnetic fields are really low compared to ambient magnetic fields, and for example, compared to Earth magnetic field. Thus, MEG recording take place inside a magnetic shielded room to reduce ambient magnetic field, and to record low magnetic field in the order of femtotesla, these magnetometers and gradiometers require cryogenic cooling. They are placed inside liquid helium. As due to the temperature of liquid helium, this sensor cannot be placed on the scalp. It needs to have it's needed to have thermal insulated space. This is why sensors are placed inside the rigid helmet. You can see also on the right of slide 6, and yeah, to keep this thermal insulated space between scalp and sensors due to cryogenic cooling. You can ask how is the brain producing this magnetic field, and you need to know that neurons are interacting together due to electrical potential. We are obviously not recording the activity of a single neuron, but we are recording the activity of a population of neurons acting together in the same way. And the next question we can ask is why do we need to record the magnetic field if neurons are working with electrical potentials? And it is also possible to record this electrical potential. It's the role of electroencephalography, which is commonly used in the field of epilepsy. There is several types you can see on slide 7, from low density EEG, including 24 electrodes, until high density EEG, including until 256 electrodes. EEG is cheaper than MEG, clearly, and low density EEG is quite easy to use and is really commonly used by epileptologists and in the field of epilepsy, including refractory and not refractory patients. And on slide, I switch on slide 8, you can ask also, why do we need to record both magnetic fields and electrical potential if they're recording the same activity? What is the added value of the magnetoencephalography as magnetic field is related to the electrical potentials? And I switch on slide 9. EEG and MEG are not sensitive to the same sources inside the brain, and EEG is more sensitive to radial sources, which are originating from gyrus, whereas MEG is more sensitive to tangential sources, which are originating from sulcus. Moreover, EEG is influenced by different layers between sources and sensors, as cerebrospinal fluid, bone, skin, etc., but not influenced by the distance, or not much. And MEG is highly influenced by the distance between sources and sensors, but not influenced by the different layers between sources and sensors. Based on this, magnetoencephalography has an added value compared with EEG. It has been proved by some other study, and for example, this study I've shown on slide 10 has shown that magnetoencephalography can change the decision of the multidisciplinary epilepsy team in some cases. And for example, you can see on the slide 10, on the left panel, each point is the dipole corresponding to one interictal discharge. You can see it's highly clustered, and after watching the MRI again, the multidisciplinary team have seen that there is a lesion on the right panel, and this patient had surgical resection and was seizure-free for 2 years after the resection. on slide 11, this other study have shown that the resection of the whole cluster of interrectal discharge is correlated with a better surgical outcome. There is more patient stage free if the cluster of interrectal discharges was resected, even if it doesn't match perfectly with the lesion. Now, I'm sure I convinced you that magnetoencephalography was so wonderful, and I switch on slide 12. I explained to you that the magnetic field are lower with distance, and you can imagine the fact that as children had smaller head circumference, and as a sensor are placed inside a rigid helmet, there is a greater distance from brain to sensor in children than in adults. Most of MEG devices are based on adult head circumference, and thus leading to low signal-to-noise ratio in children than in adults. It's possible to record the magnetic field in children with this device, but it's not perfect. One way to overcome this limitation is the use of pediatric magnetoencephalography. As you can see on the right panel, there is different types, baby MEG, pediatric MEG, which are based on the head circumference of a child. Nevertheless, the helmet circumference fits perfectly with only one head circumference that the child gets at one specific age. Thus, child with larger head circumference than the helmet circumference could not have an MEG with this device and these devices. And in younger children, smaller head circumference will lead to a low signal-to-noise ratio again, as with adult head circumference devices. And then on slide 13, there is a new type of magnetometers called optically pumped magnetometers, and which doesn't require cryogenic cooling. As the most limitation to place the sensors on the scalp was cryogenic cooling, this type sensors can be placed directly on the scalp. How does it work to record the low magnetic field? There is a cell full of rubidium, which is heated to give the transparency to the rubidium, and when the magnetic field passes through the rubidium, it modifies the axis of rubidium atoms, and the amount of light is different according to the magnetic field passing through the cell. On slide 14, you can see one of the most important publications in the field of optically pumped magnetometers, which have shown that OPMs were able to record the activity generated after a movement. It was similar with cryogenic magnetoencephalography, and on the middle panel, they recorded this activity also in moving condition. I did not mention it earlier, but you can imagine that to record the magnetic field with a cryogenic MEG, you need to remain still inside the magnetic shielded room and to get the head perfectly inside the helmet. It was also a limitation in children, as in really young children. It needs sedative to perform magnetoencephalography. So OPMs this time are able to record the magnetic field even in case of moving conditions. It seems to be an advantage in children also. On slide 15, you can see the first time interictal activity was recorded by OPMs in one epileptic adult and without source reconstruction on the activity. That's on slide 16. What about OPMs in pediatric epilepsy? And this is what we did in this study. We have included some epileptic children. Yes, slide 17. Sorry. We've included some epileptic children who underwent an OPM magnetoencephalography from 18 to 30 minutes with this flexible cap. You can see on the middle panel. And OPMs were locked on the cap with these blue three-dimensional homemade printed mounts. And so the children underwent the OPM magnetoencephalography and then a cryogenic magnetoencephalography of the same duration to compare the most comparable techniques for the recording of brain magnetic field. Then slide 18. We have visually detected interictal discharges, and then we performed a comparison of amplitude and signal-to-noise ratio between both modalities, and also performed source reconstruction on isolated spikes and on average spikes. Spikes are interictal activity, commonly described in epilepsy. On slide 19, you can see the population. We've included 5 patients between 5 and 11 years. All of them were suffering from focal epilepsy, not all of them from refractory epilepsy, 2 of them only. And you can see in table 2 that the amplitude of spikes was higher for OPMs compared with cryogenic magnetoencephalography in all patients. And then that the signal-to-noise ratio was higher with OPMs in 4 patients. On slide 20, you can see the example of recorded activity at sensor level, and you can see the SQUID acronym is for cryogenic magnetoencephalography, and at bottom the OPM signal. You can see the activity, then the average interictal discharges, and on the right, you can see the magnetic field in the sensor space, which is comparable between both modalities. On slide 21, you can see this time this magnetic field in source space, in green for OPM and in blue for cryogenic magnetoencephalography. And it is the example for one patient. In this patient, sources were distant from less than 5 millimeters. It was the case in 3 patients. Less than 5 millimeters is the range of spatial resolution of cryogenic imaging, and in the 2 other patients, sources were distant from less than 15 millimeters. Then on the slide 22, you can see again the source reconstruction of average spike in cryogenic magnetoencephalography in blue, average spikes in OPM in green, and each pink point is the source reconstruction and isolated spikes. And on the left panel, it is another type of source reconstruction to compare if it was reproducible with another source reconstruction method. And you can see that all spikes were clusters around the average spike. Then slide 23. This study have shown that our design was easy and quick to place on the head of children, and also easy and quick to digitize. It was around 10 minutes to digitize the position of OPMs with an electromagnetic tracker, which is the commonly used method of digitization in cryogenic magnetoencephalography. Then our device was comfortable for children. These epileptic children are used to have an EEG cap, so it was not surprising for them. And all of them were watching a movie without complaint. Then slide 24. As I've explained earlier, we found a higher amplitude of spikes in all patients with OPMs and a higher signal-to-noise ratio in 4 patients. It's due to the reduced brain-to-sensor distance. And the intrinsic noise of OPMs is the same than the intrinsic noise of sensors in cryogenic magnetoencephalography. Nevertheless, the signal is noisier during the OPM recording due to the movement of sensor inside the remnant magnetic field in the magnetic shielded room. Thus, the OPM signal was noisier than cryogenic imaging signal. And it's probably the reason why one of our patients had not a higher SNR in OPMs, as this patient had really large movement continuously during all the recording. And thus I was not surprised when I've seen the results. And this patient had similar SNR between OPMs and cryogenic MEG recordings. It's not surprising. Then we found similar neural sources, similar to cryogenic MEG spatial resolution, as less than 5 millimeters in 3 patients and higher in 2 patients. And it's possible we have recording 2 distinct sources in this patient during the during both recording, or maybe we have detected another type of interictal discharges. And as these recordings cannot be simultaneous, we cannot assess this with certainty. And on slide 25, the lack of simultaneous recording is a limitation of our study. OPMs and cryogenic MEG cannot be performed simultaneously. It's possible to perform EEG simultaneously. Nevertheless, it's a bit disturbing for children, less comfortable. We have included only 5 patients and we have placed only 32 OPMs. Not on the whole scalp, only around the presumed epileptogenic zone. It's also a limitation of this study. And we had no reference standard in the field of epilepsy. Reference standard are intracranial EEG or surgical resection. This slide 26, you can see that OPMs are working in pediatric epilepsy. And slide 27, we have demonstrated that OPMs are able to detect interictal discharges with a higher amplitude and a higher signal-to-noise ratio in most patients than cryogenic MEG, with a similar localization value. And OPMs could have a significant impact in assessment of childhood epilepsy for all reasons I've explained. Cryogenic MEG have some limitation in childhood epilepsy. Thus, OPM could be the future. And slide 28. For the future, there is some improvements. For example, an improvement in the digitization method, as there are some methods with more accuracy, as shown in the study on the table 6. And it's also quicker to perform digitization with a 3-dimensional scanner. which allow to perform this in 2 minutes, which is more comfortable for children. And you can see the results on the left. Then on slide 29, as I've explained that the remnant magnetic field and the movement of sensors inside the remnant magnetic field is leading to noisy signal and a reduction of the remnant magnetic field could help to have a less noisy signal and to improve again, to increase again the signal to noise ratio during OPM recording. And it's the outcome of these field milling coils, which compensate the remnant magnetic field inside the magnetic shielded room. Then slide 30. During all this presentation, I spoke about interictal discharges or spikes, which are not during seizures. And these interictal activities are not matching with the seizure onset zone. And thus the recording of seizures could be helpful to determine the seizure onset zone and thus the epileptogenic zone, due to the cryogenic MEG device, it's not possible to perform prolonged recording as long as to record seizures. As OPMs allow to perform recordings where patients are moving, it's possible to perform longer recordings, and I hope some ictal recordings. And then slide 31. If all of these improvements are possible, maybe OPMs could replace the cryogenic MEG in the pre-surgical assessment of refractory focal epilepsy, and maybe with the help of ictal OPM recording. And I thank you for your attention. I hope it was clear for you.
Yeah, thank you so much, Odile. This was a wonderful presentation. And this is such amazing work, and I hope it will help a lot of children in the future. Yeah, thank you so much for your presentation. So my question would be, like, is this device more expensive or maybe even less expensive than the devices are currently used to assess basically the origin brain region of epilepsy in children? Will it be difficult to build a lot of these? Yeah, let's start with that. Thank you.
Thank you for the question. The OPM-based magnetoencephalography is less expensive than cryogenic magnetoencephalography. Thus, it could allow to more generalize the use of recording of magnetic field recordings. Nevertheless, it's still more expensive than conventional EEG, as I've shown low density EEG, which is the reference in the field of epilepsy. I'm not sure it will replace, I could say I'm sure it will not replace low density EEG, at least in the near future. Nevertheless, it could help to generalize the use of magnetoencephalography, as it's less expensive than cryogenic. It's also less impressive for children, etc. So I guess it could generalize in some reasonable measures.
Really big upside that, the children can move around a little bit and
Mhm.
you still have accurate recordings. Is it also, can you record basically now, even in younger children, that you couldn't record from before with this technology?
Um, we were able to record the brain magnetic field in really young children, but always with sedatives. In the field of epilepsy, when the exam was required, there is an anesthetist who was present and give sedative to the child, and the exam was possible. But this type of exam will be more convenient to perform the exam in children without sedatives. Thus, without drugs, it's more convenient. It's possible to move a little bit, and it's sensors are moving with the head. It's not mandatory to keep the head perfectly fitted inside the helmet, as sensors are always fitted with the scalp. Obviously, it's not possible in aggressive children. It's not possible in. There is such pathological condition where it will be complicated, but yes, it will be easier in young children.
Yeah, I'll ask one more question and then I'll give Frank the opportunity to ask. Um, how about the training of the person performing the recording? Do people have to be highly trained? I'm just thinking of, maybe in places where there's like a low density of highly trained personnel, especially also, I think that affects everywhere around the world after COVID, everyone quitting, like not everyone, but a lot of nurses and so quitting their jobs. Like, do you have to be more trained or less trained than in previous methods to record these?
Um, I'm able to perform it alone. I guess it's more complicated in children because you need um, to speak with the child, to speak with the parent, to explain things to child and parent together. It's not uh, always simple, but I can put it on the head of children alone. I guess it's possible in low density EEG also. I don't perform it really often, and yes, it's the advantage is it's not necessary to glue the electrode in low density EEG. Electrodes need to glue on the scalp. It's not needed here. It's like I don't know, a swimming cap. I guess it's the correct the correct word. You put it on the head and you lock the sensors on the cap. Previously or after the position of the cap, it's both are possible. Um, yeah. I,
That's wonderful. Thank you so much. Frank, did you have a question?
Yeah, thank you very, very much for the presentation. I have a couple of questions, some more general and one or two on the slides. So, first of all, which devices could record an actual epileptic seizure, and what does this recording here shown tell us about epilepsy when it doesn't, when it can't record an actual seizure?
yes. EG. In fact, it's not the problem to record seizures. If the patient uh, has a seizure within the cryogenic magnetoencephalography, perfect, we can record it. The issue is that seizures are generally not frequent. Some patients had as seizures less than one per month, and then we cannot wait for 1 month inside the cryogenic imaging. You can say we cannot wait 1 month with EEG, but it's possible. We can perform some 2 weeks recording with low density EEG, and we can try also to increase the seizure frequency by some I don't know, drugs removal, some light stimulation, etc. So it's possible to record seizures with cryogenic imaging, but it's really rare due to the seizure frequency. And the OPM magnetoencephalography could not be as long as prolonged the EEG as I guess, because with EEG you can go to toilet, etc. You can not take a shower, but yes. But with the possibility to move inside the magnetic shielded room, longer recording can be performed as the patient can eat, drink, can read, I don't know, sleep, etc. Was already sleeping was already possible inside the cryogenic imaging, but not eating, drinking, watching a movie, reading. I don't know. Yeah, prolonged recordings will be able due to the opportunity to move inside the MSR, the magnetic shielded room.
Yeah, thank you. So, since this is on children, what are the main differences between epilepsy in children and in grown-ups?
Oh, uh, there are several. uh, Epilepsy is more frequent in children, etc., due to genetics issue. The Here we focused on children with epilepsy due to the great gain in this patient, the great advantage in this patient to have the this to the reducing of brain to sensor distance, which is more important in children. It could be usable in adults without. There is no problem to replicate in adults. We were interested in this particular cohort due to the great advantage in this population.
Yeah, so I've grown up with a person in my family system with epilepsy, so I kind of know these situations where yeah, very special, I have to say. To my knowledge, there have been kind of hundreds of internal differentiations of epilepsy. How did that improve in the last years, and what is the closest next other neurological phenomenon that epilepsy could be confused with?
Could you
Yeah,
repeat your question, please?
I'm asking about the internal differentiation of epilepsy because, to my knowledge, there are kind of hundreds of types of epilepsies, and how did that situation improve? Are there kind of more generalizations, or did it even differentiate further? And what is the next type of neurological phenomenon that the epilepsy could be confused with?
Mhm. This type of device uh, is mostly used in focal epilepsy. It could it could have some advantages in generalized epilepsy also. You're right. There is several subtypes of epilepsy, and I'm not sure we can count them because there is too much, and we are discovering some subtypes right now. But it could be interesting also in generalized epilepsy to better understand the connectivity between brain areas together. Um, I think it's more helpful in focal epilepsy, as the aim is to locate precisely the epileptogenic zone, and there is also several types of epileptogenic zone. They could be wide, it could be a network, it could be a highly focused zone, and the main advantage of magnetoencephalography is to precisely localize some types of really focused epileptogenic zone, and it can highlight it in such different zone of the brain. Epilepsy could, the epileptogenic zone can be located in, I will say, almost all the brain areas. It's possible to have in each brain areas, and thus the aim is to locate it, I don't know, in the frontal area, in the frontal pole, or in the, I don't know, hippocampus or amygdala, to know if it's possible to remove the zone. It's the aim in the refractory focal epilepsy, to know if you can remove the zone to reach seizure freedom in this patient. And it's possible, yeah, to highlight this zone with this type. I guess it could have some advantages in other type of epilepsy also, as I've said, for connectivity in generalized epilepsy, for example, or to better know the mechanism of generation of seizures in some other type of epilepsy. It's not it's not done again.
Yeah, thank you so much. So my last question would be on the slides on page 15, you have these graphs. What is this color differentiation between red and black?
Oh, between red and black, it's the it shows the area where spikes are have the most the higher amplitude, and which are probably, it's not different spikes. It's not different interictal discharges. They're arising at the same times, and you can say there is a propagation. We can record these spikes from different areas on the scalp, and the red line show you the most the higher amplitude of the spikes, and probably the epileptogenic focus, the focus of this activity is located near to these sensors. It's not a study of my team here in Erasmus, so I cannot say you where the sensors were placed on the scalp precisely, and they didn't perform source reconstruction. If the thing I can see on EEG and the thing I can see on OPM magnetoencephalography, I can say there is the most high spike.
All right, so it's just over a certain threshold. So yeah, thank you very much. Very fascinating, Katarina. I don't know if you want to open it up.
Yeah, thank you so much for explaining this to us. Yeah, if everyone has any more questions, please raise your hand or use the chat option, and to ask a few more questions. We have a deal for around 10 more minutes. So yeah, feel free to ask questions if you have some, or use the room chat option. Odile, is there what is next? Like, what are you working on? You know, because this is published, this is already from the past. Like, what are you working on next in this field?
I'm working on ictal recordings just right now. Yeah, it's more difficult to perform it as I've explained because seizures are less frequent than interictal activity. But yes, I'm trying to perform it, and yeah, the improvement also of our current current device how to get better signal, and then how to get in other age, in adults with refractory focal epilepsy, in younger children. Yeah, so in as, as I perform some clinical research, it depends on the patient I can get by clinical activity also, of course.
Yeah, that's wonderful. Are you also maybe involved in, is there plans to have a company sell those so more people get access to this technology? Is there any work or plans in distributing these helmets basically to, around
Um,
the world?
OPMs are, I don't know. Yes, there is a company. I'm not involved at all. QSpin, which is based in USA. I guess. Yeah, there. Our OPMs in the studio are QSpin, and you can you can buy some if you want. And I know there is other companies. I guess Field Line maybe is also a manufacturer of optically pumped magnetometers. Um, I don't know if right now there is other. I'm not sure. Don't take this as precise information. Um, yeah, I'm not involved in such company, but there is possible to buy OPMs, to buy magnetic shielded room if you want. It's already possible.
Great, thank you. That's wonderful. And yeah, we if there are no more questions right now, we wish you all the best for the future. And this is really amazing work, and I think it will help a lot of children around the world. So congratulations for doing this work, and for making it your life to help children with epilepsy. That's quite wonderful, and we wish you all the funding and all the luck for this research. Thank you, Adil.
Yeah,
Thank you.
and can I just add that your English is fine. There's absolutely, I didn't have any problems
Thank
with
you.
when you said in before the talk that you kind of could be have some there could be some problems.
Yes.
Absolutely
Yes,
not.
I'm
I
always worried about my English.
yeah, but yeah, absolutely fine and great talk. Thank you so much for participating.
Thank you so much.
Yeah, I agree. There was no reason to be nervous.
Thank you.
And I hope you come back maybe with updates further along. Um, maybe in next year, so you come back and update us with more of your really important research. Thank you, Adil.
Thank you so much.
Okay, so and thank you everyone for coming. I don't know, Adil, if you saw the chat, everyone says thank you that your research
Yes, I've
is really
seen.
wonderful. Yeah, thank you everyone for commenting, for participating, for being here and staying. And yeah, follow the Club Science Society if you like talks like these. Um, we will have today Dr. Long, and he will talk about exercise-inducible metabolites suppresses obesity. And yeah, tomorrow we'll have a room about mapping microglia and astrocyte activation in humans. Yeah, follow the club, come back, and thank you, Adil. Thank you so much. We really appreciate you coming here, and we hope you come back. Okay, enjoy the rest of your day, everyone. Bye, Adil.
Bye.
Okay, I'll close the room in 3, 2, 1. Bye, everyone.